I'm Susan Elden. I'm a health advisor at DFID based in Ghana. And my presentation is on the health financing system, but within that context of how the National Health Insurance Scheme, which has been going for about 10 years, as a mechanism and as a part of that wider health financing scheme, and then within the broader context of that, within this notion of universal health coverage and how the NHIS, so National Health Insurance Scheme and the National Health Insurance Agency. So I'll use both of those acronyms to describe what I mean. And I think Katrina really helpfully set the scene on talking about those different dimensions, and Neil has already stolen most of my points about Ghana, so I hope that you've forgotten some of those. So for those of you who may know Ghana or may not know Ghana, Ghana is a country that is roughly geographically the same size as the UK, but with about half of the population. So 25 million people, and for the most part, it's been a stable, fairly quiet country. I came from Nigeria, so I'll first of all start with a caveat. I was working in Nigeria for 3 years, and so I've been in Ghana for 4 months, and I'm not a health economist, so I'll also start with that caveat. But one of the things that my mum said when I moved to Ghana is she said, I don't hear about Ghana in the news, so I think that's a good place to go. And I think that actually is part of, Ghana's a smallish country. It's a stable country. For the past 100 years, their economy's been based on things like cocoa and gold exports. But in 2010, Ghana recently moved to discovering oil. And so the big question for Ghana now is what to do with that oil revenue and what that means both for the country and that growth portfolio. But my presentation today is really going to be a little bit of an overview on the demographics of Ghana and what Ghana's about for those of you who don't know the country context. And then moving on to the NHIS, a little bit about where it started, where it is now, and then talking about that more broadly within the aspects of purchasing, quality, and universal health coverage. And then, because I'm a development partner and a donor, what that means to us as one of the stakeholders that are sitting there in Ghana. So I've given you a little bit of the country context, and you've seen it on the map there. This is some of the macroeconomic picture, and really where Ghana looks at how it is doing on the wider portfolio about growth, GDP, and those indices. And I think just the graphs, the kind of key things that stand out to you is it's currently going the right direction at present. And it looks to be a very healthy picture. So if you look here on GNI and how per capita income has brought up, there's two things to notice. One is it's almost been a doubling. The second thing is this sort of threshold is what World Bank classify as the threshold for middle income country status. So Ghana is now in middle income country status. And what that means is that has a lot of implications for sovereign lending, for how development partners see how we work in what's a low income or a middle income country. But a lot of this, the other interesting thing about this is in 2010 they did a rebasing of the GDP. So again, it's not an exact science, but that also has implications of really pushing that up into middle income country status. Second graph again shows another really positive trend of GDP, and really towards the end a quite exponential rise, and a lot of this people feel has to do with the discovery of oil and tapping into that. And then again, quite dramatic poverty decreases. So at present, a really healthy macroeconomic picture. The questions for us are really sort of threefold. What about the future? So there's no guarantees that we will stay in that middle income country status. And so if we don't, if Ghana falls back into that low income bracket, what does that mean? The second thing is, there's no guarantee that growth will continue, and certainly at this rate. What the economists tell me in Ghana is that a lot of it is based on commodities, and so there's a lot of external factors that have nothing to do with what's happening within Ghana. And so I mean, economists anticipate all sorts of things, but the ones that I've talked to have said that we can expect a plateauing and possibly even a decline. And so if that is the case, what does that mean, within the broader picture? And then thirdly, it's a nice picture on the poverty indices going down, but one of the things that we look within that is the Gini coefficient and things to talk about inequalities. And the two things that are concerning to us in Ghana is that there's significant regional variations. So poverty in the northern region and in the Volta region have actually gone up. So this is not, although this is a good macro picture, it's not the picture across the board. There's still significant poverty. And so what people have described it to me is Ghana looks very good on paper, but it's still behaving like a low-income country. And also in terms of the human development indices and the health indices, it still looks very much like a low-income country, but that is trying to go the right direction. So then I want to quickly whiz through what it looks like on the health picture of that. And really the kind of two graphs show, again, an overall positive picture on the macro side. So dramatic increases in life expectancy. We've seen it go, let's see, in 1960, 46 was the life expectancy, and it's gone up to 65. So a 40% increase in a relatively short period of time. But also, Ghana likes to think of itself as achieving much better than its neighbors. So if you look at the countries and the states around it, Ghana's doing very well on life expectancy, on its declines in infant and child mortality, on its declines in maternal mortality. So on those big health-related indices, Ghana's doing very well. And we can think of all sorts of reasons why that's happening. I think the big picture is on the spend side, it's quite healthy. But what we want to look at is where is that spend going, and is that going on the right things, and is that spend actually yielding those results when we look towards the future? I think the other thing to really note here is that the portfolio of total health spending has changed dramatically. So again, going back to that rebasing of the GDP, middle income country status, donors have started to ask the questions, two questions. One, do we want to keep giving the same amounts of funds and resources to Ghana? And two, how do we want to do that? In the past, we were all in something called a swap in sector budget support. Now that's dramatically changing and shifting. We had 5 people in sector budget support. We're now down to 3, and 2 of those have dramatically dropped their levels to the point to where 2016 it looks like DFID will be the only person investing in sector budget support. So again, the Ministry of Health and the Ghana government is now bearing a substantial burden of the health expenditure, much more than it has in the past. One of the things so on the good side, we know that money spent on health is going up, and that's a good thing. But what is it going up on, and what are we seeing the yields from that? One of the things that's happened recently is in 2011 in Ghana, they did the wage bill. They passed the wage bill. And so what that meant was it was a shift in all of the public sector salaries. So everybody was moving into a band. That pushed a lot of people up in bands. But what that also did was that increased expenditure massively. So what happened was the Ministry of Health had a budget, and then when the wage bill was passed, they had to go back to the Ministry of Finance and said, in actual fact, this doesn't cover our bill. So when that happened, Ministry of Finance said, okay, Ministry of Health, you've got your money, cover the wage bill. But what that meant was that in 2013, on things like capital investment, infrastructure, the budget that was there, 0 was spent. So if human resources and health workers are absorbing such massive amounts of your salary and you're not getting those gains from that, where are you moving towards the future? And I think that's one of the questions that we're trying to ask. I think the other big question we're trying to ask is, as these indices get better, life expectancy increases, maternal mortality drops, you're having an aging population and you're having non-communicable diseases. That's going to cost even more. So knowing that healthy trends in the population actually mean that you need even more revenue or more efficiencies to keep this status quo or to keep the system going. So I'm going to do a snapshot through the National Health Insurance Scheme from 2003 until where it is today in 2014. We've just had our big happy birthday celebration, our 10-year anniversary of the National Health Insurance Scheme. I think Neil gave a really useful context and background about this. And I thought one of his points that was most interesting was in the beginning, donors and development partners and a lot of us as externals were very skeptical about what was the design and the makeup of the National Health Insurance Scheme and the NHIA. But also we were asking the questions about what is this going to do for the poor? What is this going to do around poverty? What is this going to do, around those scenes that we were looking at as development partners? And Ghana did two really useful things. It got all of its political parties together and it said, you know what, we don't really care. We think this is right for us here in Ghana. And they went ahead with it. And what's been interesting and useful about that process is that in actual fact that has helped the stability of the program, that an investment and the actual financing of that has remained consistent throughout those 10 years. It's had bipartisan support. So it's had a really healthy start. It's been Ghana owned, but it's facing really big challenges at this stage. And just to kind of talk you through the journey, so in 2003 the Act was passed by Parliament. And then the kind of two things I'm going to talk about really is coverage and purchasing models. So you started out with coverage at 7%. And then the model for purchasing was something called fee for service. And that was something that was replacing what was called the cash and carry system, which was just, you go in and whatever you get, you pay your cash and you have your service. So the fee for service was really an input-based thing. You go to a clinic and the National Health Insurance reimburses you for that, based mostly on volumes and on inputs. So there wasn't a lot of cost containment. But as you can see, utilization started really going up. Coverage started really going up. And then something happened. So all of these facilities are now accredited. And then in 2010, there was this sort of shift where the expenditure started to outpace the revenue. And so then things started to slow down, and people were asking the question of, timely reimbursements. The providers weren't happy about that, but also that kind of big question is, we're either going to have to create more efficiencies within the system or have better cost containment or increase the revenue, because at the moment, with that outpacing, it's not working. But you were still having this massive utilization at like 30-fold increases of outpatient attendance. And then coverage started to stagnate as those, as those different models came through. They implemented something called DRGs, which is diagnostic related groups, as a method of trying to say, okay, let's not just have this fee for service, you come in and get your service, but let's try to group these under conditions and have some uniformity. So we have these 500 conditions. And that was successful, but it wasn't successful in cost containment. The other thing that was interesting about 2010 was I was talking to Neil about this was our equivalent of the Black Report. There was an independent report produced and supported by Oxfam that said, is this really benefiting the poor? Is this really doing the things that it claimed to do? And is it really on a solid enough footing to continue? And the two interesting things that happened from that Oxfam report was, again, Ghana got together and vehemently addressed those issues. First of all, sort of seeing it as an external attack. But secondly, from what I could see, really getting their act together and making those changes, but being very transparent about what was working and what wasn't working. So there was a lot of things about, the coverage levels are 60, 70%. And when the Oxfam report said, well, in actual fact, is that initial enrollment or re-enrollment and who's getting what and how much are the poor getting, then NHIA started taking a really hard look at that. And so in the latter years, it's really been a lot about financial sustainability, about cost containment, and really thinking about the future. The capitation pilot in one region, the Ashanti region, has been one thing that they've been looking at as a key mechanism for cost containment. And then the e-claims management, which is again about the timeliness. So that's the current picture of NHIA. And I just want to contextualize that because I know we're talking about lots of different things here today, and we're talking about universal health coverage, we're talking about health financing systems more broadly. And I thought this graph was really helpful in terms of the nice thing about universal health coverage is it kind of forces you into thinking about what are those areas of health financing you need to look at. And then, so your revenue collection, your pooling, and your purchasing. And then it kind of says, okay, and then how does this impact on utilization, quality, and financial protection? So I think it's a really helpful kind of contextual background. And there's lots of things that you can discuss around this, but the primary focus I think that we can talk about in relation to Ghana is really about purchasing and the benefit package, but what that means about quality. And I think that for the context of today, I think that's where the relevance lies. I'll quickly go through on that side of the health system financing, the revenue side and the pooling side. On the revenue side, when it started out, it was seen as a very progressive system. So and what I mean by progressive is that the bulk of the resources came from taxation. They introduced something called the value added tax, which was 2.5%, and that had, again, bipartisan political support. It was seen as a good thing, and it was progressive because it didn't unduly burden the poor. It's been stable from the inception, so there hasn't been dramatic, if anything, there have been increases in the revenue, steadily rising increases, but not at the same pace of expenditure. And so that brings up the whole question of, is that revenue, revenue stable, but is it sufficient? And I think that there's really a general consensus that there does need to be increases in revenue somehow. So it hasn't really gone into depth, or I haven't seen the analyses yet, but one of the questions is whether to increase the revenue and how popular that is, how to do that through legislation and the various procedures in doing that. So we really need the evidence to show that that's needed and the economics to show how that happens. Secondly is how much is needed to increase the revenue in relation to the cost containment that needs to happen. And I think we're still trying to work through the science of how much that's needed. And then finally, where that revenue should come from. There's a number of different things being talked about in Ghana. One of those is having a road levy tax. One of the things I'd really like to see is on the tobacco and alcohol tax side things. And I think those could be really positive movements. But again, what we're trying to balance is priorities in politics, because you can increase premiums. And you could put those premiums, onto the middle income and the wealthier paying people. Is that politically popular? Are you going to see the drives there? So there's a lot of trade-offs on the revenue side, but that's just a sort of brief some of the issues around that. Then the second function is really about the pooling. Again, Ghana from the very start had a single pool, and what it used to have was these community-based health insurance schemes, so these little sort of scatterings of health insurance schemes based out in the districts. And so what it did was harmonize those within the whole NHIA package. So again, big single pool was shown to be, the early evidence was that it offered good financial risk protection. The only question about pooling is within the pool, so within that big single pool, there's separate strands. So some of that is the Social Security and National Insurance, some of that comes from the VAT, some of that comes from the donors. And so there seems to be an element where we can increase some efficiency there. But I want to talk about purchasing and quality, and I want to talk about Grace's story. And there's a couple things you should notice. One is I'm a very bad photographer. My photography skills are probably even worse than my health economic skills. But Grace, if I can actually see which one she is. This is Grace, actually. And that's probably good because you're supposed to ask for permission and get identification, everything anyway. Grace lived in Volta region, in a little rural area, not that little, but a very typical rural area of a place called Vegbe Palime. And it's about 40 kilometers from Hohoi. And I don't see anybody nodding their head who knows where the Volta. Yes? Good. Okay. So a few people. So I'm trying to get you to imagine, right? So taking it out of us as, funders and policy people and economists and all of this. Why does all of this matter to a woman sitting out in the middle of Ghana? Why does any of this, what we're talking about today, matter? And I was there for a different reason, but Grace stood up and she said, I was there for a maternal and child health thing, and she stood up and she said, I'm 8 months pregnant, I've been to my clinic, I've got this card, but in actual fact I haven't renewed it because I'm supposed to go to a separate office, which is in another town, to renew it. It's been a bit of a, it hasn't been easy for her to renew it. But she was pretty disappointed, and she was adamant in complaining. And in actual fact, when I first heard this, I liked this because I said, this is civil society, and this is people talking about their rights, and this is people demanding what they want. But I also thought her arguments were completely legitimate. What she was saying is, I have this card which told me I was supposed to have free MNCH care. But in actual fact, when I go to my local clinic, I don't even know what that is because there's no midwife there. Nobody can deliver my baby. Then the second thing she said was, I've got to take a taxi 40 kilometers to the big regional tertiary center out in Hohoi. Now, that's fine, but I've got to pay for a taxi. And how is that free MNCH care? But not only that, her biggest concern was, if I go into labor in the middle of the night, I've got to find a taxi to get myself out there, and I really care about my health outcome and the birth outcome of, my unborn child, of when I'm going to give birth. And so she was asking about, what does this card actually provide that she was promised on free MNCH care? Secondly, what kind of financial protection does it provide when she's still got to get taxis? She's got no guarantees. There's drug stockouts in the local clinic. And then finally, is she even going to get a decent birth outcome? So what are the health outcomes that this whole thing provides? So of course this put us on, okay, we got to go check out the clinic and find out what their story is. And when we went to the clinic, basically what Grace said was true. There was one healthcare worker there. The midwife had been off for a month, and fair enough. I mean, she's entitled to a holiday and a break. She was one midwife serving this entire population. And I think the other thing is we have to be careful not to demonize, clinics and come down on them as, you don't have drugs, you don't have health workers, you don't have those things. But there was a real breakdown between the community and what that clinic provided. And so this health worker, who was frankly doing her best, but not able to do much. And so I said, okay, are you accredited under the health insurance scheme? She said, yes, we are. And I said, so what does that provide? And she said, well, I know the drugs come from the National Malaria Control Program. So the prophylactic drugs under that come from there. I know the vaccines come from Gavi. I know some of the donors are providing the family planning. So in actual fact, this idea, this continuum of care and this package of care wasn't really the case. The second thing she said is, there's not a midwife. There'd only been 10 deliveries in that clinic in the past quarter. And that's really low, and that's not what we expect. But she said, look, I'm a health worker, I'm doing my best, the midwife is doing her best. NHIS doesn't pay our salaries. We're paid our salaries from the Ministry of Health and the Ghana Health Service. So again, you've got that separation, that there's quality and all those expectations under NHIS, when in actual fact your health worker is part of a completely different system. And then secondly, when I asked her, I said, so are you on the DRGs or the fee for service? She said, I don't know. And rightly so. She was a healthcare worker. She didn't really understand how the NHIS worked. And you don't expect, I think, low-level clinic health workers to know those things. But what struck me was this massive separation between what the provider understands and knows about health insurance and what NHIS and what the health insurance scheme says it provides all those things. And so the message that goes out is, you have a card, you get free MNCH care, you go to your clinic and this is what you get. And the reality was in this situation was that none of that was happening. And there was levels of disappointment from the patients, levels of disappointment from the providers, and then certainly from the purchaser, the NHIA. Obviously, if those things aren't working at that level, they're not content either. So I want to talk a little bit about, I hope that frames the discussion a little bit on purchasing, and purchasing in relation to quality. And so I think the purchasing part of the national, well, as you call it, the health system financing system, the purchasing is the interesting aspect. And the aspects about that, and I think Katrina followed on from that, is what you want to ask in purchasing is what you're purchasing, so what's in that benefit package, who you're purchasing from, so what is the range of providers there, and how are you purchasing that. So I'll go through that on the Ghana side as to the experiment within Ghana. So the benefit package and Ghana's experience on the purchasing, we know that there's been a direct relationship with quality, and they've seen that. Although I would say that there hasn't been a lot of monitoring, and again, we don't really, everybody has a different understanding of quality and what that quality means. If you take a snapshot across Ghana and say, are you getting a quality service? If you ask different people, you get very different answers. But so the actual package in Ghana, again, one package, comprehensive, covers the entire population, and it's seen as quite a generous package in the sense that 95% of outpatient conditions are covered. The only exclusions are things such as like, you know, renal dialysis and cancer treatments and things like that, which in actual fact you don't really have those services in the first place. So in principle, you have your card. Most of the things, if you walk into an accredited outpatient, you should be able to have those services. The issue has to do with, and this is where the link is to quality, is that NHIA isn't actually responsible for all of those things. There is a split between what the Ministry of Health provides as well as what NHIA provides. And that split isn't something that was a deliberate split. NHIA wasn't designed to do everything for all people. It was designed to be an agency under the Ministry of Health, providing a certain level of coverage and financial protection for its population. But when you look at something like, I guess first of all, the prioritization. So how do you cover your if you want to take that bird's eye view and say for the population, we want to invest in the greatest goods, so things like primary health care and prevention. Well, this is where the split becomes important, because actually the Ministry of Health purchases a lot of those things. You know, the vaccines, the basic commodities going out to clinics, and it's not just the Ministry of Health, it's a lot of donors. I mean, through global funds, through Gavi, and through all of us, we say, you know, prevention, primary health care, and then that's where we put our money. So that starts to skew the NHIA towards much more of the curative and the tertiary sort of aspects. And also skewing it much more towards the urban and wealthy, because if you don't have those things at your primary care center in a rural area, you're going to go to the biggest tertiary center. I think secondly is the continuum of care, and I talked about this a little bit with Grace's stories. There's an assumption that you have a package, but what's provided across that package for the individual, they don't really know, nor does the provider necessarily know. So even though within that benefit package, not everything is directly under the control of NHIA. And then I think most importantly is the health worker salaries. We know that in the dimensions of quality, what service your health worker provides you is a really important aspect of that. But health worker salaries are linked to the Ministry of Health and the Ghana Health Service. So there is not a direct relationship there, and so that does have an impact on quality. Second aspect is who to purchase services from. And I think this is another example where Ghana has been, again, quite bold and from the onset, very bright and very bold, saying we know that people are not just going to a local clinic. We know a lot of people are going to faith-based services. We know that a lot of different people are going to the private sector. And we also know that the private sector isn't one homogeneous group. It's 40 different things from your little drug seller to drugs all the way up to your services for the elites. And so you want a package that can cover all of those because you recognize that your population goes to all of those for services. The biggest issue is how do you create a level playing field across from those? So how do you stimulate competition to make people want to be part of the scheme, but then how do you make sure that it's level for them? And I want to give you two quick examples of this. The public subsidized is primarily given through what's called CHAG, which is the Christian Health Association of Ghana. So again, they're part of the overall structure, but they're faith-based, and they tend to serve rural primary care areas. Now they're taking on quite a high burden of an unhealthier population. They take on a riskier part, and they're saying you're reimbursing us at the same rate, but we're in actual fact not seeing the same patients, and we're not. So if you, under the DRG, if you pay us all one flat rate, we're having to absorb a lot more of that. We don't feel that it's fair. Private sector, again, stimulated by very different incentives, again wants to see different things coming from that. So I think we have to recognize that who we purchase it from matters in terms of quality, because there are different incentives amongst all of those different providers. And then finally, how to purchase, and this is about the payment provider services. Ghana's experimented with 3 different models. First was fee-for-service, second was DRGs, which are those diagnostic related groups, and thirdly is capitation. We're currently at capitation, and capitation has been a pilot in one region. I think there's a consensus that capitation will need to be rolled out across the country, but there's big questions as to how to do it well and how to maintain the support, because it has been a bumpy ride within that particular region in introducing capitation. I've already talked a little bit about that, and I don't want to go too much into the detail, but fee for service got the coverage up. It was volume based and input based. DRGs was about making sure that you've got consistency across, but both of those didn't achieve cost containment. So capitation was deliberately introduced to address cost containment. But the issues really with capitation are, can you get the timely reimbursement? Can you get the accuracy and the forecasting right? So the idea with capitation is you say, okay, you have a primary provider, and we're going to say that this population goes to this area. And the idea is that we will forecast what you need and we will reimburse. But it hasn't been an exact science. It hasn't been as accurate as it's been thought, and the reimbursement hasn't been as ideal. I think broadly, all of those aspects are what we mean in relationship to quality. So when we think about quality, we know that purchasing, what we purchase, who to purchase it from, and how we purchase it is one of the key drivers of quality. And so this is something that we're still sort of coming to terms with in Ghana. I think it's also fair to say that you've got various different stakeholders looking for different things and calling different things quality. I mean, obviously, all of us have to achieve financial sustainability or you don't have a scheme. But that's the key aspect of quality that a purchaser is looking at. But if you go all the way down to a patient, I mean, what Grace would like to see for her card is, she wants to see a comprehensive service. She wants it to be affordable. She wants it to be there at her primary care clinic. And she wants it to be effective. She wants to have a good birth outcome. And you can say, okay, that's a fair thing to expect as a patient, but are the resources enough to ensure that across the whole of the population? And so those are the sorts of trade-offs and the aspects of quality that Ghana is grappling with. So then just broadly to talk about the issues within health financing and national health insurance, more broadly, the opportunities and challenges going forward for Ghana. I showed you on that little step graph as to where NHIA is today. The biggest issue on everybody's mind is financial sustainability, because in actual fact, to have an NHIA, to have a scheme, you have to have a financially sustainable model. At the moment, with expenditure outpacing, it isn't financially sustainable. And so they're looking at a number of different ways to do that. But I think they're grappling with the changing demographics and the increasing needs in the population, as well as the different types of payment systems and the trade-offs those entail. And then I think one of the key drivers is you have to look at where's the money going. And upwards to half or more than half of the money in the national health insurance goes towards medicines. And so how do we get, and there seems to be two trends, is one that there's an overutilization and there's a higher cost to medicines in comparison to other countries around there. So how do you actually address that aspects of medicines? And the other thing is, within all of those purchasing models, medicines are separate. So you can have capitation, DRG, all of these different things, but medicines are separate from that. And so there's a real kind of meaty case of what we need to do specifically around the cost of medicines, and that being a key driver. Some of the challenges around the historical, structural, and the design issues have to do with the accreditation procedure. And again, you know, so the public system is accredited, and then you can say to the Christian Health Association or private, come on board, be part of NHIA. And their question is, what do we get from it? So what does it make sense for us to be accredited to do all of those things, when in actual fact we have our patients, we have our customers, our clients, and you know, we've got a system that's largely working. The other thing is there's levels of accreditation. So what stimulates you to be at the top of the accreditation or providing the best quality as a provider, when in actual fact you only need to do the bare minimum? So is accreditation the way forward, or something like contracting possibly a different way to do that? Another area is a functional IT system, and this really cuts across. This has been something that I've learned about. I think having a functional IT system is a complexity across everyone. I don't know those of you who are familiar with the US and the UK system, but nobody's got a functional IT system that works perfectly. And Ghana's trying to do this and asking all these questions, but also Ghana recognizes that having a functional IT system is something that can be really transformative within the package, because what it can do is authenticate your users, and so help with that time lag. It can also make sure that the reimbursements happen much more in real time. But the other thing is, we don't know where a lot of the leakage is happening, and so a good IT system can help you with all of those things. So it's quite an interesting and exciting area. Last 2 points is really about the evidence. Somebody in NHIA said to me, Susan, we don't know the null hypothesis. We went into this, but we didn't have a lot of data saying this is how bad the system is and this is what we're going to achieve. So there wasn't a deliberate M&E system. There wasn't all of these things set up. Ghana has started what I would suggest is a policy-driven reform agenda, but it hasn't had the ability to have really good research, really good evidence, really good data collection to back it up. And I think this is an area where donors and development partners can help it, because they're actually just scrambling to do the right things in the right way and keep that commitment going. But there needs to be a learning that goes on with that. And really, I mean, the issue on evidence is, we know now that national health insurance increases utilization, so much so that, you know, everybody starts attending and then expenditure goes up. But does that actually make a linkage to health outcomes? And I think even in the most you know, fantastic systems, there's that huge difficulty in saying, what does this mean in terms of a causal relationship with health outcomes? We can't really answer that, but we want to get closer to answering that, because for quality, we really want to know is, does this make a difference? Does this make a difference to the lives of the people? Not just do they turn up to a clinic, but do they get the services at the clinic? Do they have, you know, safe childbirth and those things? And particularly for the poor. So those are the big issues that we're all looking at. And then I think I wanted to talk a little bit about universal health coverage, because I think universal health coverage is both a blessing and a curse, in the sense that the NHIA started well before there was even this term of UHC. And NHIA was designed to do certain things for its population. Then you introduce this global concept of universal health coverage, and this is where we're all going. And then Ghana is suddenly in the limelight that it's got this system, and here's universal health coverage. And then now there's all of these questions asked and holes, picked in the system and all of this. So universal health coverage has been a blessing in the sense that it's actually helped you to define the areas you want to work on to improve the system. But it's been a curse, I think, to the extent to where it's actually oversold the functions and the ability of the NHIA and almost overpressured it. If you come to Ghana and meet with the folks with NHIA, they'll have a big smile on their face, they'll welcome you, but you can see they are running hot and they are doing everything they can and to keep the wheels from moving off. And so I think that there's all of this global pressure because of universal health coverage and because Ghana is now seen as a model, that they want it to be the reality and the shining example that it's sometimes seen as. And then finally, I want to just quickly talk about the role for donors and development partners, both within the context of NHIA, but then broadly within health financing. And this has been, again, Neil stole my thunder well before, and when he was talking about that, now that Ghana is a middle-income country, our role as a funder is diminishing dramatically. So we make the assumption that we come to the table and we say, this is what you need to do and this is how you need to advocate and these are the kind of things you need to do. But when in actual fact, with our money diminishing, there's less about what we're able to provide in terms of resources. We're still able to provide influence and advocacy, but we need to very much ask the NHIA and ask our ministries of health is what ways can we help you advocate based on your priorities and your future vision. Within NHIA, there's just to sort of give you a flavor of the tangibles, we provide support to national health insurance through our sector budget support program. We also provide it through something called the AME program, which is the, I'm going to get this wrong.
African Health Markets for Equity.
African Health Markets for Equity. And that is demand side. It is looking at certain aspects of NHIA, and it's so the other donors are covering things. They're covering broad areas. DFID has this is a centrally funded program. The reason I don't know as much about it is because it's funded from London, but I tend to work with the stakeholders there. The other thing that it does is it actually has an IT platform, and that's the part that I'm really excited about. But it is looking at private sector provision. It is looking at demand side financing, and so those are two aspects where we as DFID have a niche within that. And through the sector budget support, what we want to say is actually with sector budget support, we don't want to over-monetize. We don't want to have to, have them have massive reporting constraints. It works out to being about £2 million. And somebody in the NHIA said, Susan, it's great, and we want donor funds, but in actual fact, when you look at the whole budget of NHIA, we can get more through our inefficiencies and our cost containment rather than chasing after donor funding, writing proposals, having to do M&E frameworks, and all of the things that you might require. It's not where our incentives are. So if you can do something that benefits us, that's great, but we can actually be more smart and savvier about creating more efficiencies within the system. So then more broadly within health financing, I think there's time. Okay. 3 key areas. Health financing, and that's through our sector budget support. And we have this mantra that we want to be on budget and we want everybody to be together and all of this, and we want to see efficiency gains. But in actual fact, the landscape and the architecture is changing dramatically. We used to be one of 5 donors providing sector budget support, and now we're going to be one of the last ones. And these kind of old principles we have to continually to question, where do we want to invest in the long-term sustainability of a middle-income country? Secondly, we want to see good primary health care and prevention, because that's obviously, from our perspective, that's where you get the greatest gains. But the important thing is we don't want to hive those off, as saying, okay, we donors are going to provide all of these things and then leave you to do the curative, the expensive, and the inefficient things. So we need to have a clear understanding of how we do these priorities together as partners. And then finally, I think this just goes back to the final point about grace, is having somebody like Grace stand up and say, I've got this card, I'm not really sure what it provides me. Having good civil society is going to be the key driver of what shapes and influences the health system. So we as donors and development partners might like to think, you know, we've got all of these ideas and we have all of this influence, but in actual fact, if poor people and if the average population of Ghanaians can be the fundamental drive in helping the reform and reshaping the system, that's going to be the most powerful influence in what creates the sustainability of the system. So that's it. But I just wanted to say in conclusion, I mean, again, I said I've been in Ghana for a short period of time. I'm not a health economist, but it's an exciting time for me in Ghana because I think what they're doing is, I think they're doing quite a bold experiment, really. And I mean, it's gone beyond experimentation in that it's had 10 years. I don't think we know the answers, but I don't think there's any health system that has it perfect and knows the answers. So I think we see the Ghana, both the NHIA and the health financing system is a very positive thing, but with lots of questions about the futures where we need to know where our roles we can play and how we can best support something that had a very good start, has a lot of potential towards the future, but it just needs to be honed in as to where we can provide the best support. And that's it. Thank you.